Hi, good afternoon, and thank you for joining today's webinar on lymphedema prevention program with body composition. We are thrilled to be joined by Dr. David Weintritt, breast surgeon and founder of the National Breast Center Foundation, and Kristen Lupton, PA from Virginia Cancer Specialists. They have a great program to share with you today, so thank you both for participating. And Dr. Weintritt, I will turn it over to you.
Okay, thank you, Julie. Appreciate that. Well, we all get asked to involve ourselves in a lot of advocacy initiatives in the month of October. Hopefully, when we do, it's something that we feel very passionate about, as Kristen and I do, relative to bioimpedance testing, both for lymphedema and body comp analysis. We'll cover both of those topics on the event this evening. And certainly we hope that individuals will learn maybe some more about the importance of this. I think perhaps also realize the great practicality. I love things in the combination of surgery that we can define as both elegant and simple, meaning this great technology that is very simple and easy for us to apply and offer to our patients. That's really when we see traction in the space. Devices that give us information we can't get on our own, that provide results that we can act upon that equal a different in outcomes for individuals. And I think that really sums up a lot of the data and why we work so avidly with the SOZO platform and bioimpedance testing for our patients. So let's dig in. Because regardless of where you are, I know at least us on the East Coast, it's after hours, and we like to get into the content. So no surprise to those of us involved in surgery and medicine, when you have too much fluid in the wrong part of the body for enough period of time, it causes problems. Problems that people are acutely aware of and often lead to irreparable harm. In the field, in the world of lymphedema, specifically in our world of breast cancer-related lymphedema, that same concept is true. I certainly don't have to explain to anyone on this event what lymphedema is and what potential issues can occur as a result of it. Other than we have some very practical modern approaches that allow for us to all be more active, more proactive, and more accurate in our assessment. In particular, and what we use in my office and other offices in our practice, Virginia Cancer Specialists, is the SOZO device, initially for baseline and follow-up testing for lymphedema, and then now also for body comp analysis, which Kristen will talk about more later. Go to the next slide. So it's not just me who feels strongly about it. It's not just our patients who often, interestingly, when we're having new conversations with breast cancer patients, one of the things, whether it's a legacy issue that they may have seen in their own family or something that they've read about, lymphedema is often very high on their list of concern. Clearly survival, what's my plan? But lymphedema and how that finds its way into their outcomes is incredibly important for our patients. So guidelines exist, and I think a lot of the guidelines, and you'll see as we go through some of our major organizations, have probably always had a stance on lymphedema in regards to acknowledging the importance of it. But now that there actually are proven technologies that make a difference, then it's even easier to establish guidelines and a very repeatable recipe to be followed to make an impact for patients regarding lymphedema. And look, I feel all the surgeons on this call hopefully have low lymphedema rates within their population. But looking at the literature, it can range anywhere from 5 to 50%. And if you're that N of 1 as a patient who has lymphedema, and somewhere in that progression from stage 0 subclinical to stage 1 or 2 or 3, or heaven forbid 4, if that individual knew that there was an opportunity to detect and derail and prevent progression in chronic disease, then these are guidelines we need to pay attention to and something we need to have a plan for. Next slide. So NCCN principles related to lymphedema, you'll see a fairly consistent theme here as we go through. Early detection is key. There are a variety of methods that have been used, some very sophisticated and effective, for assessment of lymphedema. You'll see some listed here in this slide. I think it's worth mentioning. Pyrometry, which is a very sophisticated measurement of volume of a limb, 3D imaging, which can be actually useful, especially in scenarios where patients are embarking upon evaluation for, do I need some kind of corrective for a later stage version of lymphedema? And then you have very basic tape measurement and volumetric measures. What makes bioimpedance testing, and again, in our case with SOZO device or something that will work similar to it, is you get to attach this high level of sophistication, but you have portability, affordability, and something that you can very repeatably and reliably apply. So when we're looking at guidelines and there's sort of a request or a mandate, then not only do we identify this to our patients as a potential risk of their diagnosis and treatment, that we also are very proactive in establishing reliable measurements both before and after surgery, and a pattern that we follow consistently. Next slide. In APBC, we'll comment very similarly in regards to standards. And one of the issues that you'll notice is obviously we're screening, but the ability to refer to high levels of care, sophisticated care in regards to lymphedema management. And what makes technology like BIS testing or bioimpedance testing so helpful is that we're able to refer patients who actually need their help. If we can reliably operate in patients and reduce their risk, but still no risk exists, have technology that we can track and monitor individuals that gives us actionable data, and in the majority of cases confirms that they're fine, there's no need for lymphedema management for those. And then when actually patients do have a rise in their lymphedema levels, confirmed compared to baseline, then we can refer them on. All of us on this call in the field of surgical oncology, medical oncology, or reconstructive surgery are listed as individuals who need to have a lymphedema program in place. Next slide. The National Lymphedema Network, no surprise, would be very vocal in regards to the importance of how we manage individuals. I think it's interesting when you look at this article, and I'll summarize for you their statement. Risk is lifelong. So for starters, all patients should be informed of risk. And risk management should begin at the beginning and then continue on throughout their journey relative to the risk of lymphedema. And that is a modality of intervention that either removes or harms lymph nodes. So it could be surgery or radiation, potentially chemotherapy as well, that may then put them at risk. And those are the individuals that require information, informed consent, and then a plan. Baseline pretreatments baseline measurements prior to therapy are key. You'll see fairly consistent across all of the different societies that weigh in on the importance of lymphedema programs is the importance of a baseline measurement that is both accurate and then can be compared to follow-up after each individual's intervention. Subjective complaints matter, but objectivity is key. So while we certainly would still take into fact when someone commented on a limb that felt heavy or some perception of swelling, it really is consistency of pretreatment and post-treatment fluid levels with the technology as reliable as SOZO that allows us to more objectively manage the patients. And then you'll also see that practicing healthy habits matters. Lifestyle issues like obesity can influence lymphedema risk. And this is really nice where we have one device that's utilized by my entire team to both evaluate the acute phase relative to lymphedema and then help individuals track their wellness relative to obesity and body composition. And there's actually some synergistic effect for lymphedema. And of course, Kristen will talk about some of the benefits of cancer risk that can exist with body composition optimization. And bluntly, early stage leads to the ability to intervene. Stage 0, which is subclinical, or stage 1, which is edema that is not pitting or persistent, allow patients to have the option to be saved from the chronic issues related to lymphedema. And while, I think a lot of the pictures that we may show in talks can be somewhat historic, there are patients that continue to have higher levels of lymphedema that are real significant morbidities and disabilities related to breast cancer-related surgery or other surgeries affecting regional lymphatics in the axilla or the groin. Next slide. So this summary, you'll see all of these different entities having a vested interest, whether it's a lymphedema expert or a surgical society or a cancer-related society. And consistently across the board, you'll see the mention of two things, as I've mentioned already, and this is sort of a repeating theme, is be prospective and use technology that is actionable. And so throughout, you'll see the mention of prospective surveillance and the use of bioimpedance spectroscopy to provide accurate information and allow early intervention based upon early detection in individuals to be seen and treated when appropriate. And why I think BIS or spectroscopy and bioimpedance, which obviously is performed by the SOZO device, shows up so frequently. For those of you who have seen, I think I have reviewed it in the past and reviewed it again recently, the PREVENT study, which really went head to head of the two major techniques that we all would have access to in theory. We can all acquire a SOZO machine for our office, and we all have tape measures. And for individuals, I think between the years 2014 and 2018 that were enrolled in that study, there was a significant reduction in the risk or the development of later stages of lymphedema in the BIS arm compared to the tape measure arm. And interestingly, more individuals were actually referred to lymphedema therapy from tape measures than were referred by BIS, but fewer patients were developing lymphedema in BIS. So we really we summarize from that it's giving you a more accurate and more interpretable test and a more reliable trigger, and then a more timely treat. So that test, trigger, and treat theme you'll see as well. Next slide. So how do we translate this to practice? So we have a device that's very portable, very easy for patients to use, very easy for my staff to use, where we test. And then how do we test, or when do we test? Ideally, again, we do a baseline prior to intervention. And so we now have a practice that anytime a patient comes in, new diagnosis, we'll do a baseline just because things get very complicated and busy, and the patient's journey from the initial consultation to surgery can be quite involved. And we want consistency to be key. And the last thing, we'd like to deal with would be an individual post-op having symptoms, concerned that something has happened. We do a measurement at that phase, but we don't have a baseline. And now we're not really sure whether they're having a true trigger or not. So the key is to test early and then test often for the first 3 months, or excuse me, first 3 years, and then continue to test, because this can be a lifetime issue. Now we'll drop the frequency, and personally, every time patients come in who fear or carry this baggage, that operation on one side prevents them from ever using that extremity in any medical or physical or other or fashion without worry of risk, I'll sort of reinforce or encourage them to be normal, be you. When you come in and you adhere to screening and the measurements remain consistent from baseline to post-op and every year after, it gives them the freedom to not have to worry that they're in an active phase where they could actually do themselves harm. Save the therapy, save the strict precautions for individuals who actually are triggering by having an elevated result. And then it's appropriate to focus and limit and protect those when it matters. And treatment can be quite simple. If you can identify subclinical or stage 1, the treatment does not have to be that sophisticated. And the results speak for themselves relative to the data from the PREVENT trial of the number of patients who triggered and then never went on to develop any version of chronic lymphedema. Next slide. So here's some information and data from my practice, Virginia Cancer Specialists. So we're in Northern Virginia. We're very fortunate to have access to physical therapy and lymphedema therapy. Of our 5 sites that have a SOZO device, here are the numbers over the last 3 years. Now, 2025 is not complete yet. I think these numbers are through August. Next slide. Let me go next. Oh yeah, so this Alexandria, you'll see this is my clinic, so the Old Town location, and we do the majority of screening. So actually about 2/3 of the SOZO measurements that are done of all of the surgical and medical oncology patients that go through my practice. And believe me, I'm busy, but I'm not that busy. But it really just reiterates that from not day one, but for a while, we've had a focus that this matters. If it matters to our patients, if we have data that confirms that we have the ability to take something that could be a chronic disease that still occurs with certain frequency, and we can provide certainty to individuals at every phase of care, where they stand, and when a trigger result occurs, as you'll see in a patient example shortly, that we can actually intervene on their behalves, just as if we would when it comes to reducing a risk of recurrence of their cancer or other complications related to their journey. The devil's in the details. And this is not some small minutia detail. This is a big detail. Fortunately, it's a relatively infrequent scenario where we have someone who requires all of the different efforts that we have to treat lymphedema. But this risk exists for every single one of our patients having axillary surgery or harm to their axillary lymph nodes. Next slide. So I mentioned a case. So of surgery based upon what appeared to be an excellent clinical response, had breast conservation surgery. She had mastectomy surgery with the targeted axillary dissection and sentinel lymph node mapping. So overall, relatively small number of lymph nodes removed, but this combination of axillary surgery, neoadjuvant chemotherapy, post-mastectomy radiation, based upon stage of her disease, and then we'll look at her information on the next slide relative to her measurements. So after the initial phase, fortunately, having had a baseline evaluation, we saw an elevation of Emily. She allowed me to share her name and picture. And so we tested, and as a result of this confirmation or elevation, it was a trigger, and then it led to treatment. And I referred Emily to a very reputable lymphedema therapist that I've been fortunate to work with for the last 10 to 15 years, who initiated very basic measures, then immediately brought Emily back down into a safe range. And you can see now that as we continue follow up through her journey to survivorship, which most recently was just this past September, she's now returned almost back down to her baseline. So subclinical or stage 1 trigger based upon a consistent method of testing led to an evaluation, treatment with an appropriate referral to a highly specialized physical therapist, and a good outcome for Emily. Next slide. And I'd like to say, living proof. I can't tell, now Sozo can't tell either, which side Emily had surgery on. And it's really all based upon reliable data and the ability to act at a time when patients can still have their complications mitigated by this technology. Next slide. So we're all specialists in one way or another on this call. Our lymphedema therapists should be considered the same. And in many regions, they're pretty scarce, at least at the highest levels of training. So we really need to value, just as I think we would all value in our clinics, that if the doors were open for anyone to be referred, now obviously those of us in the practice of clinical breast surgery in the community setting, we're used to taking care of a wide variety of problems, but ultimately we know the things that really need our specialization and expertise to make a difference. And so the concept is to have a program where we can use technology, screen the large numbers of patients that we're treating, both medically and surgically and with radiation, that our lymphedema therapists just physically don't have the bandwidth or capacity to see all of them, and then separate those who have the need for action at the right time for action, and really use the resources that we have well. A device that's scientifically sophisticated, but very simple to use, that we plug into a wall We can have someone step on that thing and get a measurement, every 5 minutes, and it will not wear out at the end of the day, and it will be happy to see, the 30th or 40th or however many patients that we might ask it to see in a given day. That's not reasonable for our lymphedema therapists. And so we need to have a model of care and consistency that uses those resources at the appropriate time. Next slide. And think of this, again, the devil's in the details. We know the value of screening for breast cancer with mammography. It has reduced the mortality from breast cancer. 1 in 200 women roughly who undergo a mammogram will have a cancer found. Yet we're very passionate about making sure that those happen on appropriate intervals because we know what an impact it makes to have a diagnosis at early stage instead of later stage. This is really no different. It is different, but it's no different in regards to we have a technology that's readily available, and we have proof of the value of applying it in a consistent manner, proven by published data to show what the impact of screening consistently, having a reliable trigger that results in then appropriate action for appropriate specialists and good outcomes for our patients. So of all the issues that we do that we feel strongly about, hopefully everyone will find value in feeling strongly about the ability to allay concern. And then when there is an issue, allay or prevent more significant outcomes or morbidities regarding lymphedema. Next slide. So I'm going to pass the torch to Kristen Lupton. So just for those who have the benefit of working with APPs, yeah, I think you all know none of us can survive without an amazing team. In both in surgery and the clinic, I would certainly not be able to provide as high level of care as I can without someone like Kristen as part of my team. And her passion for our patients is really one of the things that led us to start a body comp program. There's no way that I would have the bandwidth to spend time talking to patients when we're trying to manage individuals who have new cancer diagnoses and require surgery. But if we are doing things properly, we are going to have a lot of survivors. And we want those survivors to be thrivers. We want them to be free of lymphedema. We want them to be free of recurrence. We want them to be living normal lives. And we want them to have every opportunity possible to reduce their risk of cancer and recurrence. And so with that, I'll turn the program over to Kristen and discuss how she manages patients with our SOZO device and body comp analysis.
All right, thank you very much. Well, thank you all for joining us tonight. And I am excited to talk to you all about my experience and what I've done with the SOZO body comp analysis and how it's become a really valuable tool in our high-risk clinic. So about 1.5 years ago, Dr. Weintraub and I created a more formal high-risk breast cancer clinic, and that's when I began incorporating the body comp analysis into those high-risk visits. So since that time, I've done analysis on over 100 patients. Some, several of those are repeat patients, but 100 baseline patients, and it's really helped to assist with the goal-oriented breast cancer risk reduction strategies that we recommend for our patients. So next slide, please. So candidates for body comp are really any of those patients that we're all seeing on a regular basis who are high-risk individuals for breast cancer, those with a gene mutation, lifetime risk over 20%, previous atypia or lobular carcinoma in situ, and of course those with a personal history of breast cancer. We're always talking to them about how to prevent reoccurrence and the things in their control. So next slide, please. So the SOZO body comp provides a comprehensive analysis of fluid and tissue, giving us clinically validated data. The fluid analysis includes total body water, and it's divided into extracellular and intracellular fluid. And the tissue analysis includes fat-free mass, fat mass, and muscle mass. And it's the fat mass and the muscle mass that I really focus on, those primary data points that I focus on with patients to help them, see what's happening with their risk and risk reduction strategies for lifestyle modifications. Next slide, please. So in cancer patients, we can't simply, rely on what the scale says and rely on a BMI. And all of us in general, we're not getting the full story about what the scale says and what our BMI is, because a lot, as you can see with these two cartoon characters, the one on the left clearly has a much higher percent body fat than the gentleman on the right, who has a much higher percent skeletal muscle mass. However, they weigh the same, and we can't say that they have the same risk for disease as each other. So as presented in the article that you can see listed at the bottom of the screen, these data points were driven home that it's really muscle mass and fat mass that matter for our patients' risk. And low muscle mass, we know, is associated with a higher risk of reoccurrence, increased overall mortality, and cancer-specific mortality. Of course, more complications and more toxicities related to chemotherapy. And lower muscle mass can be associated with less tolerability of aromatase inhibitors. So we do want to know what's going on. We can't just say have an extremely low fat mass, because of course our patients need some sort of reserve, and that improves their overall mortality too. So next slide, please. So in my clinic, I introduce body comp to our patients by first starting with a list of all lifestyle modifications that reduce breast cancer risk. And a big focus of that is maintaining a healthy body weight. And it's not really about the number. Again, it's about what makes up your weight, how much fat mass is there and how much muscle mass is there. And why is fat mass important? Because we know that it increases estrogen production, leads to inflammation, altered insulin signaling, and especially for postmenopausal women, this does make them at higher risk for hormone receptive positive disease. And I think at this point, when I talk about fat mass, it's a little eye-opening for a lot of patients. They don't really, we've all been told to maintain a healthy weight, but nobody really understands why the fat component is important and why the muscle component is important. So it is a big learning point for many people. The next thing is just talking about how important exercise is, and really breaking it down for patients and saying, look, studies show that 150 minutes a week, up to 300 minutes, really reduces your risk, but don't be overwhelmed by 30 minutes here, an hour there. Just every little bit kind of adds up. And for postmenopausal women, they have a risk reduction up to 21% with that amount of exercise because of that risk of hormone receptive positive disease, and then 16% for premenopausal women. And very simply, kind of reducing your risk, the more muscle you have, the more fat you burn, reduces your breast cancer risk. So focus on strength training and building that muscle. Next slide, please. So when you have the initial results, it comes black and white, it's objective data. I can write notes on it, review what their results are for patients, make little arrows and drawings about what we want to decrease and what we want to improve. And it gives them a really actionable plan. In all of our patients, we put together an educational binder that they can leave the high risk visit with. It's got those modifiable risk factors we talked about, their body comp results that I've written notes on for them to look back on. And then we have some basic educational material, a lot of nutrition info, focusing on eat more of this, less of that. And then we do offer referral to our nutritionists who are affiliated with BCS. And then I also want to give them some sort of guide about if they're new to exercise, if they need new ideas. So I just put together some list of strength-based programs to help build that muscle mass. And most patients follow up. We have them come back in 6 months, but some who are super motivated want to see what's going on at a 3-month visit and what they're doing and how it's affecting their body comp. Next slide, please. So tonight I have put together a couple of case studies that I found, a little bit different types of patients here. And the first one is a 46-year-old female who has a breast cancer lifetime risk of 28%. She did have negative genetic testing. And I saw her for the first time last October, and she was planning to start a GLP-1 the next month. And that I know is a growing population. We're seeing more and more patients on GLP-1s. They can be amazing for our patients, but it can account, the weight loss on those medications can be up to 25% of their weight. And in the age of internet medicine and busy primary cares, patients aren't just having they aren't just having they are not having their body comp followed, and we don't really know where that weight is coming off. So if I have a high risk patient who comes through who's on a GLP-1, I really try to encourage them to say, let's follow your body comp, and that most are really willing to. So anyways, I saw her 6 months later in March. She was taking the medication and doing well. She had lost about 16.6 pounds. And then we had a third follow-up in September, just last month. She had gone on vacation, decided couldn't get the medication refilled, and felt good off of the GLP-1. So she really only took it about 6 months. And in that time, she was increasing her walking. She had not started a lot of strength training yet, but she was focusing on portion control. And even being off of it for several of those months, she was down another 4.4 pounds. So the next slide is how the body comp results can be so easily graphed for our patients, as us and the patients especially, to be able to read what's happening over this time period. And it's such a beautiful trend down and very satisfying for the patients who are having these results, super motivating. We can see her overall body weight went down about 21 pounds over those 3 visits that I did an analysis on her. And then in the next slide, we can see that it's broken down into fat in pounds, and she did lose the majority of her 21 pounds was 20 pounds of fat mass down. And you can just see that beautiful trend downwards. That again, patients love seeing that. So next slide is pretty remarkable here as we think about patients in their range of percent of body weight. She started in a very high fat mass percentage of her weight at 33.5%. And she's trended all the way down to a level that's now considered in the good range. She lost basically 10% of her body weight. She lost 10% fat mass. So that's really encouraging. And then the next slide, also being on the GLP-1, again, important to understand what's happening with her muscle mass. And overall, she maintained her muscle mass. She did put on a pound, but the bottom line is she didn't lose any, and she's doing really well. Having been on the GLP-1 and now off of it, she's still improving. And this is where I took the time. I'm like, look at that trend upwards of your muscle mass, and maybe now that you're feeling more in control of things, let's add on some more weight training and feel more motivated to see what happens the next time we check in on this. And then the next slide gives us her muscle mass as a percent of her weight, that again improved about 5% of her weight. 10% down in fat mass, 5% up of her weight and muscle mass. So she's done remarkably well. She obviously feels well. She did have a lot of help with the medicine, but regardless, she's feeling better. She's doing great here. So the next slide is a second case study. This one I think is a little bit more realistic for our patients. She still had a great outcome, but it came a little slower for this patient. And she's a 52-year-old female. Again, lifetime risk over 26%. I saw her about a year ago, a little over a year ago, for the first time in the high-risk clinic. And we did a baseline body comp analysis. And then I did not see her until just a week or 2 ago. She had some normal imaging in the meantime. She saw her GYN, and then she said, I know I need to do things. I've started making some gradual changes in the last 3 or 4 months. Not sure it's really done a whole lot for me. I haven't weighed myself. I'm not sure we're going to see a bunch of changes, but I'm trying. I'm doing little things here and there with portion control. I've started walking 2 days a week. And surprisingly, she got on the scale. And as you can see in the next slide, her overall body weight had gone down 8.4 pounds. And she was ecstatic just by that number off the bat, because it was really reassuring to her that things were happening for her. And then when we look further into her fat mass, the majority of it was actual pounds of fat that she had lost. And I mean, she looked at this and she almost had tears in her eyes. She was proud of herself, motivated, felt like the small thing she was doing was worth it, I think. And so she's, going to keep going with all that and maybe then add some. And then as a percent of her body weight, she lost a couple. She's still in the very high range, but she's trending down. The direction of that curve is perfect, losing some percent of her body weight as fat mass. And then her muscle mass maintained. Anybody losing weight, we want to make sure that they're not losing muscle mass as part of that, and she is not. And then as a percent of her weight, her muscle mass on the next slide bumped up a little bit too, about a percentage point. And again, this is where I say, look, it's going in the right direction, just adding a little bit more strength training, keep up with those dietary choices, and everything is going to go the right direction. So again, it's really helpful for patients to see these findings in black and white and know what they're doing is making a difference. And then a lot of people don't have dramatic improvements, but we can still talk about other things to do and really know what's going on for them. So on the next slide, in summary, Dr. Weintraub and I, we will put this clinic together, and we wanted it to be more than just calculating a patient's breast cancer risk score and giving them their MRI and mammogram orders and doing an exam. And the body comp allows us to measure these clinically validated assessments of fat mass, muscle mass, which really help guide our patients making these achievable lifestyle changes that are data driven, these recommendations. So if you have a SOZO, this is a huge patient population that can benefit from the information that our SOZO provides. And how I typically incorporate it into the visit is I go through all the risk reduction strategies. I ask them if they want to do it. If they do it, I have my MA grab them. It's a 30-second read, which is the same amount of time for an LDEX. And then I can see another patient while the score is calculated. 2 copies are printed, one for the patient to go home with. I keep one for the chart. I go over the results. I write notes on the copy for the patient. And then it's all in all about 10 minutes maybe. And then for those of you who've done LDEX on your cancer patients and those entering into survivorship, these SOZO body comp data may already exist, or it does exist on a lot of those LDEX previous readings. And so you may already have some baseline data for those going forward that you can start incorporating that into the survivorship program. So all in all, it's a portion of a 40 to 60 minute billable visit in the high risk clinic. And that's how I use it. So please let me know if you have any questions. And I'm going to turn it back over to Dr. Weintraub for the next couple of slides about some CPT codes and billing for the lymphedema screening. Thank you.
Thank you, Kristen. Excellent work, as always. So it's an important part, clearly the majority of focus is on a disease that's been around since the advent of time and surgery and treatment regarding lymphedema. Some methods that have been developed to essentially try to more accurately define and then ideally prevent and allow more refinement of the overall process. But all of these things that take time obviously also take money. And so the work or advocacy and the importance of this, you can see from all of the different organizations and societies that have weighed in and demonstrated the importance, have gone a long way to SOZO's testing, bioimpedance spectroscopy testing, to have a Category 1 CPT code. So 93702, the indications are individuals with breast, cervical, or melanoma cancers, which, as we all know, often result in the removal of or treatment to that can damage lymph nodes within those regional bases. Our case, it's predominantly upper extremity, but there are lower extremity applications as well. And when I queried my own practice information We actually are getting coverage for this code from the majority of payers, CMS included, but from a large number of third-party or private insurances as well. And this is not a device that we brought into our clinic to make money. I started using the very first version of bioimpedance testing that ImpediMed provided that was not called SOZO. And it looked somewhat more rudimentary and crude, but yet, we still knew even back then that there was importance in attaching an actionable value to lymphedema screening. I went through iterations of writing letters to discussing whether we would bill patients for this technology, and sort of fought and fought and fought to keep it front and center in our clinic because it really mattered that much. And I'm very thankful now that we're at a point in time where I don't have to have those conversations as often. And we actually have a service that is covered appropriately because it matters that much. Next slide. And here's a list of national payers with coverage. The biggest payer, CareFirst Blue Cross Blue Shield in the Northern Virginia area, is included in this list in our practice, as are these other payers. And we are, as I mentioned, now at a point where we can feel very comfortable both in time relative to body comp for complexity of Kristen's visits, and then for the covered CPT code for lymphedema screening for patients who are using the technology for that indication. Next slide. And so how to operationalize a lymphedema prevention program. Hopefully, this is not something that you all will necessarily need to follow a recipe. The issue is, first of all, commit to that it's a relevant issue for you, because it is a relevant issue for your patients. Realize that the majority of individuals that we enroll into our program and then encourage to stay involved in our program, and they're very committed to it. The patients are very compliant with this. They're amazed by the technology, as with so many other things that we bring to the bedside and in our operating rooms, that have been developed specifically to allow them to lead a better life. And whether it's a drug or a device or a surgical technique, they're grateful that something exists and that it matters to us as much as it matters to them, that we make sure that it's incorporated in their journey. So we identify patients as anyone having a node touched physically or by other methods. And then our team will essentially, and as Kristen mentioned, has now fortunately become very routine to them, that we'll get the information as a baseline, is essentially a vital sign. So our medical assistants are gathering patients' records and their history, and this becomes part of their history for individuals that they know will either have or are highly likely to have something occurring in their axilla relative to the staging and management of their disease. When necessary, because this is something that we are going to bill for as a procedure, we'll have our team work on chart preparation and pre-authorization, but it is very fluid and is working very well. And we are now at a point in time where all of the things that, or at least the majority, we won't say all because there will always be something, the majority of barriers and obstacles that existed no longer exist. And we can really have a caring team and a concerned patient and sophisticated yet elegantly simple technology give us information that we need. And all of this is very easy to incorporate into our EMR. And you saw the graphs, the bars, everything really tracks well. This is not a difficult report of information to interpret for us or for our patients. And again, it's actionable information, but it matters most when it's done properly, baseline, and then consistently thereafter. Next slide. And for that, we thank you. And I believe there'll be opportunities to provide any questions that you have via the chat. Julie, I think you may have been or will monitor that. We'll certainly stay online as long as we need to.
Yes, Dr. Weintraub and Kristen, thank you again so much for this valuable information. We do have a couple questions. The first is, I believe this is for the high-risk clinic, Kristen, logistically, how do you schedule follow-up screens This particular clinician is seeing 2 patients every 10 minutes, 2 days each month. They're wondering what other ways people capture them for 3-month screens.
So how often are they seeing it?
2 patients every 10 minutes, 2 days each month. So I believe this would be for the LDEC screens. How are you capturing them for their 3-month screens? Bringing them back in.
Well, my patients are, if it's a high risk visit, we reschedule it as a high risk visit, and it's either a 20-minute follow-up visit. And so within that time, I have time to do the body comp follow-up and go over the results with them. Is that?
Well,
Yeah,
I think
and
that the 3-month measurement,
Yeah.
which would relate to, I guess, survivorship patients, if they're on that kind of a schedule, that may also be related to lymphedema screening. And once we had our medical assistants consider this to be basically a vital sign, they would capture this measurement as if they would weigh someone. And then once all of that information was available, that's when either I or Kristen would go into the room and conduct our visit.
great, thank you. And then in general, Dr. Weintraub, you mentioned that you've been using the technology for some time, but how did you garner support within your practice and or at a higher level to be able to adopt and utilize the technology?
Yeah, I just continued to make it a big issue, and what would often be the case would be education, right? So, we have a practice that obviously is very sophisticated and complex. We do a large number of phase 1 clinical trials. We have, as I said, medical radiation oncology and surgical oncology. And a lot of the times, though, that when you're having a conversation with someone relative to this, is first you need to make sure that they understand, what is it we're asking and what is this disease process? Because this is not something that you'll necessarily pick up, in scanning through patient reviews of their experience. This is real world. Imagine you're going through this, and imagine you're one of the 5% or more, depending upon how involved your treatment is, that will potentially have this become a lifetime issue. Tell me about all the things that you like to do with your arms, whether it's professionally or recreationally, and then walk through and get all of the stakeholders that we need to be on our side in regards to acquiring this technology, making sure the staff is appropriately trained and appreciative of it, and just constantly putting that patient focused, patient first view in front of them, and that this is not a matter of a sort of a luxury, that this should really be considered a necessity if we're going to consider ourselves the best of the best, comprehensive, all the things that I think we would want to be. And not everybody thinks the way we do or has the training we do, but this is an easy condition for us to educate those who might be potentially blocking it based upon cost, based upon utilization, and really turn them to our side. It worked all through the time when we weren't getting routinely reimbursed, because I would just champion it and say, look, you cannot expect me to perform these surgeries on individuals and then not provide me a tool that I can use to help manage complications that are going to occur at a certain frequency. And this is the best way that I can manage those complications.
Thank you, Dr. Weintraub. And I believe we have time for one more question, which is how do you today charge for that baseline assessment, or how do you bill for it?
So we document in our notes, the risk associated with patients who are having some version of therapy involving the axilla. We document the need for baseline measurements and for follow-up. So we sort of set the table. We obviously have clinical data that we can provide if needed, but usually if we're setting the table for why this information is necessary and why it's necessary as a baseline, then we include it in our note, just as we would the indication for surgery or for other studies, and we bill for it using the 93702 code, and really from that point on, we don't have any issues. It's really become the same as doing an ultrasound or other procedure in the office.
Great. Well, that is the time that we have for questions today. There are a few open ones that we can answer offline. So thank you to all of those that submitted questions. Again, want to thank Dr. Weintraub and Kristen for their time sharing their experience. It's invaluable to hear from clinicians that are using the technology. So thank you so much for your time today.
Thank you, Julie. Thank you, everyone. Have a great evening.
Thank you.
Thank you, everyone. Thanks, Julie.
Bye-bye.
Take care.